So we're on to another group of organisms, and these are the fastidious or fussy gram-negative bacilli, or the gram-negative rods. We're going to start out by talking about the genus Haemophilus. In general, the Haemophilus are pleomorphic, so they vary in their shape and size. They are coccobacilli, or teeny tiny rods or rods. They're non-motile, they're facultative anaerobes. They will ferment carbohydrates or sugars. They tend to be oxidase and catalase positive. They reduce nitrates to nitrites, and they reside in the mucous membranes of both humans and animals. Now, the species associated with human disease, the big species is Haemophilus influenza. That is the one we will put more attention on because that's the major pathogen of the Haemophilus. There's also Haemophilus hemolyticus, Haemophilus aegyptius, Haemophilus ducreyi, Haemophilus parainfluenza, and there used to be 3 other Haemophilus species. On this slide they're shown in blue. They're Haemophilus aphrophilus, Haemophilus paraphrophilus, and Haemophilus cygnus. Now, due to sequence analysis, multilocus sequence analysis, these 3 organisms have been renamed. Actually, Haemophilus aphrophilus and Haemophilus paraphrophilus are now one single organism, and that is Aggregatibacter aphrophilus. And the Haemophilus cygnus is now in that same genus, but its own species, so Aggregatibacter cygnus. So they're very similar, the Agribacter, to the Haemophilus, but they are different enough that they put these 3 into their own genus of Aggregatibacter. So the major human pathogens in the Haemophilus organisms are Haemophilus influenzae, Haemophilus ducreyi, and Haemophilus aegyptius. Now, Haemophilus, heme means blood, and phile means loving, so the Haemophilus are blood-loving organisms, and that's what makes them fastidious or fussy. They require growth factors that are present in blood in order to grow. So these organisms, most Haemophilus organisms, are not going to grow on your standard growth medium if it does not have a blood source in it. So the growth factors that are present in blood, you have X factor, which is hemin, and you have V factor, which is NAD, or nicotinamide adenine dinucleotide, or nicotinamide adenine dinucleotide. Now, the thing about these blood factors, these growth factors, is that's one way to distinguish the various Haemophilus species, are based on if they require hemin or X factor, NAD or V factor, or both the X and the V factor. So the Haemophilus that have the prefix para usually only require V factor for growth. Now, you can look for some of the species of Haemophilus actually will hemolyze 5% horse or rabbit blood. That's another distinguishing characteristic. If they will cause hemolysis if you grow them on horse or rabbit blood agar. Now, both X and V factors are found in red blood cells. However, X factor is available on 5% sheep blood agar, our typical standard commercial laboratory media. V factor is not in the 5% sheep blood agar. However, both X and V factors are found in chocolate agar. So this is one of the reasons why respiratory specimens are always inoculated onto chocolate agar, so that you don't miss Haemophilus influenza, which is an organism that requires both X and V factors. So if you only took your respiratory specimens and streaked them out on your sheep blood agar, you would never grow your Haemophilus influenza, and you might miss a major pathogen causing a severe infection. One of the characteristics about Haemophilus and their growth requirements, such as the Haemophilus influenza organism that requires both X and V, we said that Haemophilus influenza will not grow on sheep blood agar because sheep blood agar only has X factor or hemin in it. However, if you have an organism growing on sheep blood agar that produces V factor, and these organisms are Staphylococcus aureus, Streptococcus pneumoniae, or Neisseria species, you can get Haemophilus influenza growing as satellite colonies, little tiny colonies satelliting around these V factor producing organisms. So here is an agar plate, and you can see the little teeny tiny Haemophilus influenza organisms satelliting around Staphylococcus aureus that are growing on a sheep blood agar plate. So in general, Haemophilus influenza will not grow on a sheep blood agar plate because there's no V factor in it. However, if there is Staphylococcus aureus or Streptococcus pneumoniae growing, you can get Haemophilus influenza as a satellite colony. We're going to first talk about our major pathogen, and that's Haemophilus influenzae. And of course, since Haemophilus influenzae is a pathogen, it has virulence factors, and the most significant virulence factor is its ability to produce a capsule. And like what we talked about Neisseria in a previous lecture, the capsule allows the Haemophilus influenza organisms to be subtyped into 6 serotypes, A through F. The serotype Haemophilus influenza serotype B was the most common cause of infection, especially in children. However, now that we have a vaccine for Haemophilus influenza type B, we don't see this causing as much of a problem as it used to. Not all Haemophilus influenza strains are encapsulated though. However, those that can produce a capsule are responsible for the invasive diseases. Other virulence factors include proteases. It's a gram-negative organism, so it produces lipopolysaccharide or endotoxin, and it has pili to adhere to host cells. Now, Haemophilus influenza that are encapsulated produce a variety of different types of infections, such as septicemia, acute meningitis, epiglottitis, cellulitis, and pneumonia. Now, the non-encapsulated strains can also cause infections, usually not as severe, such as otitis media or middle ear infections, conjunctivitis or what's called pink eye, sinusitis, bronchitis, and pneumonia in the older individuals. Now, meningitis is the most severe type of infection caused by Haemophilus influenza, and before vaccination, this was a common cause of meningitis in children between the ages of 3 months and 6 years. And again, the most common serotype was the serotype B. Like all of meningitis, the symptoms include a headache and stiff neck. Usually this occurred after a child was developing mild respiratory symptoms, runny nose and sniffling, things like that, and then all of a sudden the headache, stiff neck, and meningitis. The vaccination, though, has decreased the incidence of meningitis due to Haemophilus influenza type B. Cellulitis also can occur, and it's more commonly occurring in the cheek, and this is a rapid onset with pain, red, and swelling of the cheek area. Acute epiglottitis is another type of infection, and again, this is rapid onset and acute inflammation and swelling of the epiglottis. This has a peak incidence in children between the ages of 2 and 4, and the epiglottis can get so inflamed and swollen that it can obstruct the airway. So right now, you should be making these connections we talked about another organism that can cause obstruction of the airway, and that organism is Corynebacterium diphtheriae, and that is the organism that generates a pseudomembrane. Now, Haemophilus influenza doesn't produce a pseudomembrane, but it does cause an inflammation that can obstruct the airway. So I would suggest that you start making charts of, all the organisms that cause respiratory disease and all the organisms that are encapsulated and all of the organisms that do certain things, because it's very easy to compartmentalize microbiology into these are the fastidious organisms, these are the gram-positive cocci, these are, and not really think about them as in the big picture. And by the final exam, you're not going to be able to just think of a few organisms. You're going to have to think of everything. So it's really good for you to start making nice big charts now, and so that by the end of the semester you have all of the information you need, and you'll know which organisms do cause which types of diseases, and not think of them as all of the gram negatives and all of the gram positives, etc. Okay, here is a child with a Haemophilus influenza, which is otherwise known as H flu. Type B, serotype B, and you can see the cellulitis in the cheek, the very swollen cheek area, and again common in children between 2 and 4. And Haemophilus influenza serotype B used to cause very severe meningitis and septicemia in children. And remember, in meningitis, you can get disseminated intravascular coagulation, where your blood coagulates, you're not getting oxygen to the extremities, and the tissue in those areas can die. So that used to be a highly fatal infection. We're now going to talk about some of the other Haemophilus species. And the first one we'll discuss is Haemophilus aegyptius. And Haemophilus aegyptius is very difficult to differentiate from Haemophilus influenza. Now, Haemophilus aegyptius commonly causes conjunctivitis or pink eye. Now, conjunctivitis caused by aegyptius is predominantly in children, but this organism can cause a systemic disease called Brazilian purpuric fever, and this is a recurring conjunctivitis, and it can be a conjunctivitis that occurs along with a fever, vomiting, a rash or petechiae, can lead to septicemia, shock, and death. And the mortality rate can be as high as 70%. And systemic disease due to the Haemophilus influenza biogroup aegyptius is much more common in warmer climates. Haemophilus ducreyi is usually diagnosed based on clinical symptoms. Now, Haemophilus ducreyi is never part of the normal flora. So again, your light bulbs in your head should be going off. There's another organism we've talked about that is never normal flora, and that organism is Neisseria gonorrhea. Now, both Neisseria gonorrhea and Haemophilus ducreyi are sexually transmitted infections. Haemophilus ducreyi causes the disease chancroid, which has an incubation period of 4 to 14 days, and the symptoms include a painful lesion on the genitalia, and usually it's combined with a very enlarged lymph node that can be draining and pussy, and the lymph node is the inguinal lymph nodes, or the lymph nodes in the groin area. Some other species are Haemophilus parainfluenza and what used to be Haemophilus aphrophilus, which is now Aggregatibacter aphrophilus. Now, the Aggregatibacter aphrophilus we are going to talk about a little more in detail in a later lecture in this lecture, but in one of the later parts, because it's part of the HACEK group of organisms. And this organism is highly associated with endocarditis caused after a dental procedure. So a lot of these organisms are normal flora of the mouth, and in individuals that are immunocompromised or maybe have a heart condition, they are highly susceptible to getting endocarditis because during a dental procedure, you get your mouth flora that gets into the bloodstream. And in a normal immunocompetent individual, we can fight those these organisms off. But in an immunocompromised individual or an individual with a heart condition, they may not be able to remove these organisms from the bloodstream. And if they get into the heart area, they can latch onto the heart valves and cause endocarditis. So that's why a lot of individuals that have heart conditions have to go on prophylactic antibiotics prior to any dental procedures. We're now going to discuss the general features of the genus Haemophilus. So all of the Haemophilus organisms except for Haemophilus ducreyi are part of the normal flora of the upper respiratory tract and the mouth. Now remember, Haemophilus ducreyi is never normal flora, it's a sexually transmitted infection. Transmission of Haemophilus organisms is usually endogenous, so you infect yourself with your own normal flora, or through respiratory aerosols. You inhale a respiratory droplet from someone in close contact, or for Haemophilus ducreyi through sexual contact. Prevention and control: there is a vaccine for Haemophilus influenza serotype B, and you also, individuals that may be in contact with someone that had meningitis due to Haemophilus influenza, if they weren't vaccinated previously, they would be put on prophylactic antibiotics. And we're now going to move on to the second part of the Fastidious gram-negative bacilli lecture. This is part 2 of our 8 Fastidious gram-negative bacilli lectures. And in this lecture, we're going to focus on Haemophilus identification. So one way to identify Haemophilus is through direct examination, and we mentioned direct examination in previous lectures, and what that is when you look directly at a clinical specimen. So in other words, you don't rely on growing the clinical specimen up on agar medium or in a broth. So you take that clinical specimen, usually you're going to put it onto a slide. Depending on what specimen it is, you would put it on a slide in various ways, and then you would gram stain it and then look for the organisms directly in the clinical specimen. That's especially done in cases of meningitis. We talked about that when we talked about Neisseria meningitidis, where you're going to commonly get a cerebrospinal fluid in, and that is immediately, it's a stat test. Everything is dropped. You take your spinal fluid, you make a slide of it. Usually you're going to spin it down so that you get any bacteria and cells that might be there. You're going to get it concentrated. You're going to take that, whatever gets spun down, the concentrated what's called a pellet, you are going to make a slide, you're going to gram stain it and look and see what you have. So the Haemophilus in general are slender, gram-negative, usually coccobacilli, small, teeny tiny rods. They do not form spores, they are not motile. And here is your gram stain of a typical Haemophilus. And you could see it's very, very, very tiny. Some of the bacteria are a little bit bigger than others. Some are stuck together. When you see an individual Haemophilus organism, it's hard to tell if it's a rod or a cocci. Now, in a direct smear of a cerebrospinal fluid, in the case of meningitis caused by Haemophilus influenza, you are going to see extracellular and intracellular gram-negative coccobacilli. And if you remember our Neisseria meningitidis and Neisseria gonorrhea, those coccobacilli, these don't look that much different. They do have that cocci look to them, so you have to be really, really careful. You can also see a little halo around these organisms, and that would be the capsule. Now, to cultivate these organisms, they are fastidious or fussy. They Haemophilus are, or respiratory specimens. If you had a spinal fluid after you take some of the spinal fluid and do a direct gram stain on it, you would also do some platings, and you always want to plate on chocolate agar so that you can be sure that if Haemophilus influenza is there, it's going to grow. So the respiratory specimens are normally put in a 5 to 10% CO2 incubator. These organisms will grow pretty much anywhere. They can grow at lower oxygen levels. They like CO2. And growth is at body temperature at 35 to 37 degrees. Now, Haemophilus ducreyi, our sexually transmitted infection, grows best at 33 degrees and requires special media called GC agar. And GC agar has vancomycin in it to reduce the growth of any normal flora that might be present. If you can remember, in our Neisseria gonorrhea lecture, we also talked about special media that contains antibiotics in it to reduce normal flora and enhance the growth of the Neisseria. So Haemophilus ducreyi has something similar and likes lower temperatures. You should get visible colonies of Haemophilus in 24 hours. They are usually somewhat transparent, smooth, convex. Haemophilus is a lot of times described as having a mousy odor or a bleach-like odor. Now, way back in the day, way back in the day, even before my time, it was common in the clinical laboratory for laboratory scientists to sniff plates, and people with a lot of experience can just sniff a plate and know what was growing on it by what they smelled. Nowadays, we know a lot more, and sniffing of plates is not allowed at all. Sniffing a plate can cost you to lose your job, possibly. It's just frowned upon. And that's because there are organisms out there like Neisseria meningitidis and many other organisms that you are risking your life by sniffing the organism growing. So you do not want to ever sniff a plate. However, textbooks still refer to the odor. When you open up a plate in the laboratory to do a catalase test or an oxidase test, sometimes the smell just comes at you and hits you, and you don't even actually have to sniff the plate. So we do still describe the odor of certain organisms if it's very characteristic. Now, encapsulated strains will produce a larger and more mucoid colony. Of course, that's common because capsule producing organisms usually are more mucousy looking. And the organism, if it's grown up in a broth, usually when you grow bacteria up in a broth, it gets very, very densely cloudy and turbid. And that is not as common with Haemophilus. And one of the reasons is because Haemophilus requires blood to grow, and most broths don't contain blood in them. So Haemophilus does not grow very well in most broths. We talked about the X and the V factors, or hemin and NAD, and how various species require either the X or the V or X and V. Haemophilus influenza requires both X and V. So they have X and V discs. Usually you buy them in a disc. These are strips where you have your filter paper material that's impregnated with either the V factor or the X factor or both X and V. And you'd make a lawn of your organism and drop your X disc, your V disc, and your X and your V disc, and you can see where the organism grows. If it requires V factor only, it will grow around the V factor, and it will probably grow around the X and the V because there's V there. But an organism that requires both X and V factor, like our pathogen Haemophilus influenza, is only going to grow around the disc that has both X and V in it. Now, of course, you would do this on a general supportive or nutrient agar plate that doesn't have your hemin or NAD, doesn't have any blood source in it. So you want to really see, is this organism only growing around the NAD and hemin that you are supplying it on that paper disc. Now, we already said that chocolate agar has both X because it's a blood source, so it has hemin, and it has the NAD because it is hemolyzed blood. So Haemophilus influenza, which requires both X and V factor, will grow very well on chocolate agar, and it usually produces a tan, somewhat mucoid colony. Now we're going to go over laboratory diagnosis. Now, we already talked about the X and the V factor, and what you can do is take 2 agar plates, one plate that contains X factor, like a sheep blood agar plate, and another plate that has neither X or V factor, just a basic supportive media like Mueller-Hinton agar. You could take your test organism, streak it for confluence, and add a V producing organism or a V disc and see what happens on the plates. So here for our X and V requirements, it looks like Mueller-Hinton agar, so no X or V is added at all. And you can put an X and a V disc somewhat close together, and if it requires only X, it'll grow around the X. If it requires only V, it'll grow all the way around the V. If it requires both X and V, it will grow in the area in between the X and V if they're close enough. The better way to do it is to use an X disc, a V disc, and a disc that contains both X and V. So on the left, this is Haemophilus influenza because it's growing only in between the X and the V strip, so it definitely requires both X and V factors. On the plate on the right, the organism is growing all the way around the V strip, so you know that this organism only requires V factor, and this organism is Haemophilus parainfluenza. You can do carbohydrate speciation tests, and if you remember in a previous lecture we talked about the rapid tests, and these rapid tests are little tiny kits that have little cupules, and you add your organism to it and you incubate them usually for about 2 to 4 hours, and based on the color reactions in these little couplets, usually there might be 8 or 10 different reactions in each one, in per test, and you come up with a little scheme, a number scheme, you put it into the computer and it'll give you the likely organism. Another nice easy way to differentiate your Haemophilus species is to use a quad plate. So this is an agar plate that has 4 different zones, and each zone has different media in it. One zone has media that contains only X factor, the other has only V factor, another quadrant has both X and V factors, and then the 4th quadrant has a media that has horse blood in it. So another test that used to be done in the clinical laboratory that's no longer done is the porphyrin test. And this test identifies the X factor requirement. And so what you would do is take a hemin-independent strain which produce porphobilinogen and porphyrins in the presence of delta ALA, or delta aminolevulinic acid. So you would take your bacteria and inoculate it into a delta ALA media and then expose it. You'd incubate it first, usually for about 4 hours, and then expose it to UV light. And so here's what you would get. Under ultraviolet light, the organism that is positive for a porphyrin reaction reacts to that delta ALA, and the medium will fluoresce. So the bottom organism is porphyrin positive, and the top organism is porphyrin negative. But this test, like I said, is not done in the clinical lab anymore. Quad plate, that's not commonly done anymore with, your microscans and your Vitex. You don't need to do as many manual tests, but there are some labs that might do some quad plate verification tests, or if the instrument is giving inconclusive results and you're pretty sure it's a Haemophilus influenza, I would say that most labs are either going to have a default of a quad plate, or more likely a default of a kit test such as the rapid NH test. So we're going to now move on to the third section of the Fastidious gram-negative rod lecture. We're now in part 3 of our Fastidious gram-negative bacilli lecture. And in this lecture, we're going to talk about the organisms Capnocytophaga, as well as those in the HACEK group. So the HACEK group, it used to be very easy because the H stood for Haemophilus, and the A used to stand for Actinobacillus, the C for Cardiobacterium, the E for Legionella, and the K for Kingella. It still does stand for those organisms. However, for the H, or Haemophilus, the organism that was the H for the HACEK was Haemophilus aphrophilus. However, you recall in our part 2 of this lecture, we mentioned how Haemophilus aphrophilus was renamed to Aggregatibacter aphrophilus. So this organism is no longer a Haemophilus species, but it is a closely related species. The A was Actinobacillus actinomycetomycomitans. Now, Actinobacillus got its name changed to Aggregatibacter. Now, it keeps it easy because Actinobacillus and Aggregatibacter are both an A, so the A in the HACEK still is fine. Cardiobacterium ominous and Legionella corrodens and Kingella species. So these 5 organisms make up the HACEK group. So in general, these are opportunistic organisms. They don't normally cause disease, but they will if it's an immunocompromised individual or in the right opportunity. They have slower growth. It takes 2 to 3 days for these organisms to be seen growing on an agar plate. They have very small, compact colonies, and these organisms do not grow on MacConkey agar. So in your week 1 lecture notes, you have a chart that lists all of the common media, supportive, selective, differential. It tells you what ingredients they are. You should go look at MacConkey agar because we are going to be talking about MacConkey agar a lot from this point forward. MacConkey agar is very commonly used for the gram-negative rods, and that's because MacConkey agar inhibits the growth of gram-positive organisms. However, there are some gram-negative organisms that will not grow on MacConkey, and the HACEK group is one of them. or 5 of them anyway, and there are several other organisms. So for those of you that are making a chart, that should be one of your chart categories, organisms that don't grow on MacConkey. And right now you should be putting in HACEK, because even though they're gram-negative rods, they don't grow on MacConkey. The HACEK group organisms are oxidase positive. They require CO2 for growth, making them fussy. They have a predilection to attach to heart valves, which is why they are common causes of endocarditis. And they more commonly cause endocarditis in individuals with heart disease, or that have damaged valves, or that have had valve replacement and have prosthetic valves. And again, these are organisms that are normal flora of the oral cavity, which is why they tend to cause endocarditis, especially after any dental procedure. Now our H in our HACEK group, that used to be Haemophilus aphrofilus, which is now Aggregatibacter aphrofilus. This is the most common cause of endocarditis out of the organisms in the HACEK group. The organism is a pleomorphic teeny tiny rod or Bacilli, or they can be rods. They're non-modal. They ferment carbohydrates, specifically glucose, maltose, sucrose, and lactose. They are oxidase variable, meaning they can sometimes be positive or negative, so oxidase is not a very good differentiation test. They're catalase negative. They reduce nitrates to nitrites, and of course they are normal flora of the human mucous membranes. And here is what was formerly called Haemophilus aphrofilus, which is now Aggregatibacter aphrofilus, growing on a sheep blood agar plate. The next organism is Aggregatibacter actinomycetomycetans, which is again normal oral flora in humans. This organism does not routinely cause infection in humans. It is an animal pathogen. However, humans can be accidentally infected due to contact with an infected animal. In the laboratory, these are gram-negative small rods, and they are Bacilli. They can be very tiny rods. On agar plates, they tend to form what's called star formation. Kind of looks like a star in the center of the colonies at 48 hours of growth. In broth, the organism tends to be a very granular organism. If you shake the broth, it looks like granules in it, and it adheres to the sides of the tubes. It is non-modal. It is a fermenter if you add serum to the media, so it requires serum to ferment carbohydrates. It's catalase positive. It also has a variable oxidase, and it is negative for urease, indole, esquilin, and citrate. And we are going to be talking about all of these tests when we talk about the Enterobacteriaceae gram-negative rods, because all of these tests are important in differentiating the gram-negative rod organisms. So here is Aggregatibacter actinomycetomycetans, or what used to be Actinobacillus, growing on a sheep blood agar plate. And if you were to really look at this under magnification, you would see the star-shaped center if the plate were incubated for 48 hours. Cardiobacterium ominous is our next HACEK organism, which is normal flora of the nose, mouth, and throat. Can also be present in the gastrointestinal tract, and this organism tends to cause mouth infections and can cause endocarditis, of course, after a dental procedure. More commonly, it will infect the aortic valve of the heart. In the laboratory, this organism is pleomorphic. It can be varied in its shape and size. It's a gram-negative rod, non-modal. It can tend to be falsely gram-positive, so it doesn't decolorize that well. It will form rosettes and swellings. It can grow on blood agar and chocolate agar. Again, it's a fermenter, but you need serum to enhance that reaction. It is oxidase positive, catalase negative, indole positive, and negative for urease, nitrate, gelatin, and esculin. And again, we will talk about all of these tests in detail when we get to our Enterobacteriaceae organisms. And here is Cardiobacterium ominous growing on sheep blood agar after 48 hours. Here is a gram stain of Cardiobacterium ominous showing those rosettes. So the organism tends to clump together in kind of a flower rosette formation. Eichinella corrodens is our other HACEK group organism, and this is normal flora of the oral and bowel cavities. It's usually mixed with other flora, such as your Streptococci species. It is a common cause of infection after trauma. So Eichinella corrodens is very common. It's a very common cause of infection after a human bite. So if two people get into a fist fight and one person bites another person, because Eichinella corrodens is normal flora in the oral cavity, it can get into that bite and cause an infection, especially in individuals that are immunocompromised. It also is a common cause of clenched fist infection. So individuals that might clench their fists very hard and their nails puncture into their skin, it can cause a clenched fist infection. It is commonly a cause of infection after dental manipulation and also after surgery. So approximately 45% of Eichinella corrodens will pit the agar or corrode the surface of the agar. It has an odor of bleach, and again, I already mentioned we never smell our plates. We do not sniff plates, but any characteristic odor is a differentiation feature. So it does have an odor of bleach. It's non-motile, it's oxidase positive, and it is non-saccharolytic. It does not ferment. It does not utilize sugar in the presence or the absence of oxygen. This is similar to the Brucella catarrhalis organism. It is catalase negative, and it often produces a yellow pigment. So here's Eichinella corrodens growing on chocolate agar, and it tends to pit the agar as it grows on it and kind of looks like it corrodes the agar. And here's a gram stain, typical gram negative rod. Kingella species is our last organism in the HACEK group, and these species include Kingella kingi, Kingella denitrificans, and Kingella oralis. These are normal flora of the upper respiratory tract, especially around the tonsil area. They are Coccobacilli to short rods. They exist in pairs or short chains. They are non-motile, but if you were to do a wet mount on these organisms, they would look like they were twitching. They're oxidase positive, catalase negative, and they will ferment glucose. And here is a gram stain of Kingella, and these are, larger. They can be small, they can be medium shaped. They will chain together so they look longer because of the chaining. Now we're going to talk about another organism, not a member of the HACEK group, but it is a fastidious gram-negative rod, and that is Capnocytophaga. This organism used to be called DF1 and DF2 before it got named, which DF stands for dysgenic fermenters. Currently, the Capnocytophaga has 7 species. 5 of them are normal oral human flora. These require CO2 for growth. So clinical specimens are going to be incubated in a CO2 incubator so that you don't miss some of these fastidious organisms. It is a common cause of septicemia in granulocytopenic patients, so patients that have very low granulocyte counts, granulocytic white blood cells, are highly susceptible to Capnocytophaga infections. In the lab, these tend to be long, thin, tapered rod. On agar, they tend to be flat and irregular in shape. These organisms are non-flagellated, but they can seem to have a gliding motility on a solid surface. So on agar media, they will glide across the agar surface. They are adherent on agar, so they tend to be a little difficult to pick up off of the agar, and they have a yellow to orange pigment. They are catalase and oxidase negative. And here's Capnocytophaga on chocolate, and you can see that gliding motility, how it spreads away. It seems to be moving away from where it started to grow. And here is the long, slender gram-negative rods. And now we're going to move on to the fourth part of the Fastidious gram-negative rod lecture. This is the fourth part of our Fastidious gram-negative rod lecture. And in this lecture, we are going to focus on the organism Pasteurella multocida. Now, the Pasteurella are related to the Haemophilus organisms, and there are 17 species of Pasteurella that exist. However, Pasteurella multocida is the organism that is most commonly associated with human infection, and the virulence factors are not well characterized. Pasteurella multocida normally causes infection after a bite or a scratch, and it can also cause respiratory tract infections as well as life-threatening systemic diseases like meningitis or bacteremia. It is primarily a zoonotic organism. So this organism is normal flora in animals, and animals can become symptomatic when they're under stress, and the organism will start to grow and cause problems, and this is called shipping fever. So what happens is, in an individual that gets bitten or scratched by an infected animal, it can cause a localized cellulitis, inflammation, lymph node swelling, or lymphadenitis. It can progress to osteomyelitis if the animal has a very penetrating bite and actually bites into the bone. The organism can also cause a chronic respiratory disease. This is usually more common in patients with an underlying lung disease like emphysema or asthma. And what happens is it will colonize the oropharynx after it's been aspirated. It can also lead to systemic infection, which is much more common in immunocompromised individuals and in individuals with liver disease. And here's a typical Pasteurella multocida infection, where at the site of infection you'll get inflammation, redness, swelling, and you could see where the bite mark is. So it's carried as normal flora in healthy animals, sheep, dogs, rats, and cats. Now, transmission is usually from the bite or scratch of an infected animal, and cats are the most notorious for causing Pasteurella multocida infection, but dogs can also. So, of course, the best prevention is to not get bitten by an animal, especially an infected animal. But I mean, this is normal flora, so the animals may not have any symptoms at all. Stressed animals can, but dog or cat, it's just normal oral flora. Just like we humans have normal oral flora, so do animals. Treatment: penicillin, it works fine, and it is one of the few gram-negative rods that are still sensitive to penicillin. In order to diagnose Pasteurella multocida in the laboratory, you would need to get your specimen in, and usually this is going to be material from a wound specimen. It might be a blood, it could be a respiratory tract, and in a case of a meningitis, it could be a cerebrospinal fluid. And under gram stain, Pasteurella is a pleomorphic gram-negative coccobacilli that can also be somewhat filamentous. It can be a rod, like a normal-sized rod. It tends to show some bipolar staining, so it stains darker at the ends than it does in the middle, which tends to make it look like a safety pin. On agar, usually you're going to get more of a coccobacillus that you see under the microscope. If you grow this organism in more of a broth culture, or if you look at an infected tissue specimen, you will see the rod form. And here is gram stain of Pasteurella. And you're going to see that usually the gram-negative rods, they all tend to look alike. They're pink rods. Some might be a little smaller, some might be a little larger. There's only a few that have a very distinguished look to them that would make them be, a reason to gram stain them. So gram-negative rods tend not to be stained in the clinical setting. If it's known to be a gram-negative rod, usually you're not going to go to a gram stain, whereas a gram-positive cocci you might. Here's Pasteurella in a tissue specimen. You can see these nice gram-negative short rods. So under the microscope, usually you're going to see very tiny gram-negative rods where you get the bipolar staining, where the ends stain darker. So the bipolar staining is much more prominent if you use a Giemsa stain or a methylene blue stain. It's not as prominent if you use gram stain. So this organism will grow on 5% sheep blood agar, but it will not grow on MacConkey agar. It will form a smooth convex colony on blood agar in 18 to 24 hours. It's non-hemolytic. However, underneath the colony there may be somewhat of a green discoloration, which makes it appear to be alpha hemolytic, although it is not hemolytic. And Pasteurella is described as having a musty odor, but again, we never smell our plates in the laboratory. And no very specific environment is needed. This is considered a fastidious organism. However, it does grow on blood agar. We usually will incubate in a CO2 incubator, but it is one of those organisms that won't grow on MacConkey agar, whereas our typical gram-negative rods do, so it is considered fastidious. Again, growth on 5% blood agar or chocolate agar, that musty odor, and one of the very distinguishing characteristics is no growth on MacConkey. It is oxidase positive. And here you can see Pasteurella, nice growth on blood agar, nice growth on chocolate agar, and you can see the streaks on the MacConkey agar, but you can't see any organism growing, and that's because Pasteurella does not grow on MacConkey agar. So this is what you would classically see in the clinical laboratory, because in the clinical laboratory your specimens are commonly going to be inoculated onto blood, chocolate, and MacConkey at the least. Some labs will grow on other selective media as well. So these organisms are fermentive, so they will have an acid butt. They will be yellow in the bottom of a triple sugar iron agar. We talked about that in the first week lectures. It will not grow on an oxidative fermentative media. It is catalase and oxidase positive, and it sometimes these reactions can be a little bit variable. A distinguishing feature we've already mentioned, no growth on MacConkey. It is sensitive to penicillin. It's indole positive, urease negative, and ONPG positive. And we're now going to move on to the fifth section of the Fastidious gram-negative rod lecture. This is the fifth part of our Fastidious gram-negative bacilli lecture, and in this lecture we are going to focus on the organism Brucella. The Brucella organisms are not related to any other genus. There are 6 species in the genus Brucella, and 4 of these cause human disease. And the Brucella species are differentiated based on what animal they normally reside in. So Brucella abortus is normally found in cattle. Brucella melitensis is found in sheep and goats. Brucella suis is found in swine. Brucella canis in dogs. Brucella ovis in sheep, and Brucella neotome in the desert wood rat. So Brucella causes the disease brucellosis, and the 4 species that will cause brucellosis in humans are melitensis, abortus, canis, and suis. Now Brucella can produce a very small capsule, and virulent strains are able to grow and proliferate in the macrophages, in the phagocytic white blood cells in the body. So the diseases, again, we said brucellosis, also undulant fever and Malta fever. Those are different names for brucellosis. The symptoms, usually 7 to 21 days after infection, so that's a long incubation period. A person will feel very tired, get chills, have a fever. They'll get drenching sweats, body aches, headaches. They won't be able to eat. And this is due to these recurring bacteremic episodes. So what happens with brucellosis is the organism gets into the bloodstream, causes a fever, chills, sweats, and then it starts to go away. And so then, the patient might be seeming a little bit better. And then all of a sudden it gets back into the bloodstream, and again, fever, sweats, chills. It can lead to splenomegaly or enlarged spleen, lymphadenopathy, swollen lymph nodes, hepatomegaly, enlarged liver. Osteomyelitis is also a common complication, so the organism will get into the bones. Now, in its natural habit, Brucella will infect animals, sheep, cattle, pigs, dogs. It will produce very mild symptoms in these animals, or it's completely asymptomatic. The Brucella tend to have a predilection for organs that are rich in erythritol. So in animals, these are the breast, the uterus, the placenta, and the epididymis. So in animals, brucellosis leads to sterility, abortions, and asymptomatic carriage. So an animal can just asymptomatically carry Brucella, just like some of us asymptomatically carry Staphylococcus aureus in our nasal passages. So same thing in animals. Transmission, you can have direct or indirect transmission. Direct transmission is usually an occupational transmission. So farmers, slaughterhouse workers, veterinarians who are in close contact with animals are going to be at higher risk. Indirectly, you can get infected by consuming contaminated animal products. Raw milk or unpasteurized cheeses made from milk from an infected animal, goat cheese, cow milk cheese. So unpasteurized though. Also, Brucella is one of the organisms that has been associated with infecting laboratory workers. So the other organism we talked about, if you remember, was Neisseria meningitidis. So Brucella has caused serious infection in lab workers due to contact with the organism and inhalation. So risks of infection, coming into contact with animals, a laboratory accident, things like that. So to diagnose Brucella, it is a very small rod. It's categorized as a coccobacillus. It looks similar to Haemophilus. It does require long counter staining to even take in the safranin. So it tends to be very, very light pink in color. It is difficult to detect the organism in clinical specimens because it's very tiny. So in order to see it, you may need a fluorescent stain, a direct fluorescent antibody stain. These are non-motile and they do not form spores. The most common specimen types that you would get in the clinical lab that would contain Brucella would be a blood culture, a bone marrow biopsy, a lymph node aspirate, a cerebrospinal fluid, or an aspirate from an abscess. And here is a gram stain of Brucella, very, very light staining, teeny tiny rod. So in order to definitively diagnose Brucella, you really need to grow it up, culture it, isolate it. And blood is going to be, without a doubt, the most common specimen you would isolate Brucella in. The media, it does require more of an enriched media. It will grow on blood agar plates. It requires thymine, niacin, and biotin for growth. And it used to be inoculated in what was called a castanata bottle, which is a special container with media that contains all of these nice goodies that Brucella likes to grow in. Brucella abortus requires 10% CO2 for its initial isolation. So it definitely needs CO2 to grow, which is why it's fastidious. It is slowly growing. Usually it takes about 2 to 5 days to see colonies on an agar plate. It may take up to 4 weeks. So a negative culture does not actually rule out a Brucella infection because it's difficult to grow and it takes a long time to grow. Usually in the clinical lab, you'll look at your plates after 24 hours. You might look at them again after 48 hours. In some cases, for some organisms, you will look at them longer. But in general, you may not keep cultures long enough in order to definitively rule out Brucella. Under the microscope, again, very tiny gram-negative coccobacilli on blood agar plates. It's a non-hemolytic, translucent, opalescent. It has a very opaly appearance to it if you've ever seen an opal stone. It is a non-fermentative organism. It's catalase and oxidase positive. It's differentiated due to its requirements for CO2. It is urease positive within 2 hours, so rapidly urease positive. It will produce hydrogen sulfide and it grows in the presence of dyes. So there used to be a test where you could put dyes, basic fusion, and thionin onto filter paper and lay that across an agar plate that had a lawn, inoculate a lawn of bacteria, and depending on which dye the organism grew around, you can differentiate the species of Brucella that way. So the dye, here's an example of the dye inhibition test where you have your filter paper that has basic fusion, you have your filter paper that has thionine, and on the top there's Brucella melitensis, in the middle it's Brucella abortus, and on the bottom it's Brucella suis. So you could see suis grows in thionine, and so does melitensis. Suis does not grow with basic fusion, but melitensis does. So you can differentiate using this dye inhibition test. However, this test is not done in a clinical laboratory, and in fact, in a clinical lab, Brucella wouldn't necessarily be speciated. If someone had a Brucella infection, it would be considered a very serious infection, and you wouldn't necessarily have to go down to the species level. There's serological tests. You can agglutinate to detect surface LPS antigens, and that way you can speciate it into Brucella abortus or Brucella melitensis. And you would want to definitely do confirmation tests in order to really be sure you have a Brucella. There are Brucellogen skin tests, sort of like a TB skin test, where you get a cell-mediated immune response, and you would take the protein extract, well, that's what's in the skin test reagent, a protein extract from the whole organism. So you're not actually putting the live bacteria under your skin. It's an extract of protein. And if you get a reaction, an inflammatory reaction at this where you do your skin test, it would indicate that you had a prior exposure to Brucella, but it does not necessarily mean right now you actually have brucellosis. Keep in mind that Brucella is considered a bioterror agent, so it is one of the organisms we will discuss throughout the semester that is on the agent for bioterror, and so that's why if you were to isolate a Brucella from a clinical specimen, it would be immediately reported to the Department of Public Health, and I'm sure that specimen would go to the State Health Department. It would go to the CDC for further workup, just to be sure, is this an infection due to someone being in close interaction with an infected animal, or is this an bioterror occurrence? So that's just one thing to keep in mind. We're now in part 6 of our Fastidious gram-negative bacilli lecture. And in this lecture, we're going to focus on the organism Francisella tularensis. So we're going to start out with a case study. A 63-year-old male noticed swelling and localized pain on his left thumb 5 days after he was bitten by a cat. He continued to experience the pain, not feeling so good, tired, fever, vomiting, even though he was taking antibiotics. He was then admitted to the hospital. The physician incised or cut the thumb area and was suspected an abscess. However, no abscess was actually found. 5 days after admission, the patient developed shortness of breath, had a pneumonic infiltrates, and later developed swollen lymph nodes. So the wound culture that grew from that thumb infection was later identified as the organism Francisella tularensis. So there are 2 species of Francisella, but only the species tularensis causes human disease. And there are 4 subspecies or biovars. So there's Francisella tularensis, subspecies tularensis. Francisella tularensis, subspecies holarctica. Francisella tularensis, subspecies sciatica, and some of these are very difficult to say. Francisella tularensis, subspecies novicida. We just refer to all of them as Francisella tularensis, and Francisella tularensis causes the disease tularemia. Tularemia is also known as glandular fever, rabbit fever, tick fever, and deer fly fever. Francisella tularensis is an intracellular organism. It can reside within macrophages, just like we talked about Brucella can. Incubation period is 3 to 5 days, and the classification is based on its site of infection. Also, if there are skin ulcers present and swollen lymph nodes present. So tularemia is more commonly a disease of wild animals. So in 1911, there was an epizootic outbreak of a plague-like illness in ground squirrels. The organism at that time was called Bacillus tularensis, and was called tularensis after Tulare County, California, where the organism was discovered. Humans became infected by direct contact with infected animals, such as rabbits, or through the bite of a vector like a tick or a deer fly. In 1959, the genus was renamed to Francisella instead of Bacillus in honor of Dr. Francis, who first isolated the organism. This, if you want to read this report that was in the Morbidity and Mortality Weekly report. And this is a very interesting case that occurred, tularemia, that was associated with the bite of a hamster. So in April 2004, the Colorado Health Department was notified of a 3-year-old boy with tularemia. So between January 2nd and February 8th, the boy was exposed to 6 hamsters, and these hamsters were purchased from a local pet store in Denver, Colorado. All of the hamsters subsequently died within 1 week of purchase, and what they died from was diarrhea. One of those hamsters bit the child on the left ring finger. 7 days after being bitten, the child had fever, was tired, had painful swollen lymph nodes, and at the site of the bite, the skin was sloughing off. He was treated with amoxicillin clavulanate, but that didn't work. A biopsy of the lymph node, swollen lymph node, was done, and it was suspected that the isolate might be a Francisella tularensis. So this diagnosis was confirmed using polymerase chain reaction, and the serology was done to see the titer, and there was a titer of 4.096 in the boy's serum. The patient improved after treatment with the correct antibiotic, which is ciprofloxacin. Now, workers at that pet store reported an unusual number of deaths among hamsters. However, no hamster carcasses were available for testing. But one of 2 cats in the store was tested positive serologically for Francisella tularensis. So there's a theory of how these hamsters got tularemia. So the wild rodents infected the hamsters and the cats. So there were also some wild animals running around that infected the hamsters and also infected the cats. So the store set traps to get rid of the mice and rats that were running around the store. So the Francisella tularensis infection follows contact with skin or mucous membrane. So the organism, if it comes in contact with the mucous membranes, it can cause an infection. Incubation period is 3 to 10 days. Symptoms are fever, chills, feeling tired, and there are various forms of tularemia. There's ulceroglandular, glandular, oropharyngeal, oculoglandular, pleuropulmonary, and typhoidal. And these forms are based on the entry site. And any one of these tularemia forms can progress into a systemic infection, and tularemia has a 5 to 30% mortality rate if it's not treated. So we'll start out with the ulceroglandular form, and this is a form that follows skin contact where you get ulcers at the site of the infection. The regional lymph nodes, or the lymph nodes in closest proximity to the site of infection, become swollen and painful, and they may drain. And this is the most common form. The ulceroglandular is the most common form of tularemia, and it is very rarely fatal. The glandular form follows skin contact. Usually there's no ulcers that you can see, however, the regional lymph nodes do become swollen. In typhoidal, this is the type that follows ingestion of the organism, and it leads to abdominal symptoms and can also lead to a very prolonged febrile illness, very similar to typhoid fever, where the person is, feverish and just doesn't feel very well, kind of tired and achy for a very long time. Oculoglandular follows inoculation into the conjunctiva or eye, which causes a very painful, pussy conjunctivitis, and it can also cause swollen and painful lymph nodes. Pneumonic is the worst form of tularemia, and this follows inhalation or from other sites of the body, like the blood, it can get into the lungs. And this is the contagious form. So contagious is when an organism spreads from one person to another person. So tularemia is contagious. It normally resides in wild animals such as rabbits, which are the most common, squirrels, muskrats, beaver, deer. Animals may not be symptomatic. It can also get into the wood tick, which is a reservoir for infection. And in the wood tick, the tick can passage the organism through transovarian passage from one generation to the next. So here's the geographic distribution. In the United States, we have more commonly type A and type B. Now again, we said direct contact with infected animals is the most common, is a route of transmission. Hunters, people that might be skinning infected rabbits would be at high risk. You can also get infected by a bite or a scratch from an infected animal. In the northwest and midwestern region of the United States, it's commonly transmitted through tick bites. In the southwestern United States, it's transmitted through deer flies. And most cases that are reported in the United States are through ticks. So safe practices when handling potentially infected animals is a way to prevent and control infection, wearing gloves, eye protection, thick gloves where if an animal were to bite you, it wouldn't penetrate the skin, promptly removing ticks from your skin if they're attached, thoroughly cooking rabbit. You never want to cook a raw wild meat that might be infected. There is a vaccine for laboratory workers that are at high risk. However, it's not a commonly used vaccine. Military personnel may get vaccinated just due to the fact that Francisella tularensis is a bioterror agent. In where I worked, because I worked on doing research on bioterror agents, we did not get vaccinated for Francisella tularensis. It's an experimental vaccine. It's not an FDA approved vaccine, so we weren't required to be vaccinated. It's a very difficult organism to control because there's so many wild animals, and the fact that it's in ticks and flies, deer flies, so it's very close to impossible to control infection. So we're going to talk about lab diagnosis of Francisella tularensis. And the specimen types are going to vary. It can be an exudate from a skin lesion. It can be an eye or conjunctival scraping. It can be an aspirate or drainage from a lymph node. You might do a direct exam, so you can do fluorescent antibody staining. You can use a light microscope, although all you would really see if on a gram stained specimen is a gram-negative rod, so it may not help you know that this is a Francisella tularensis. Possibly combined with clinical symptoms and history, maybe, but you need a little bit more than a gram stain for Francisella. So culture and biochemical staining is dangerous. This is an organism you need to work on in a biosafety level 3 laboratory. Under the microscope, the organism is gram-negative, pleomorphic, teeny tiny rod that shows bipolar staining. So, this is an organism that if it were in a clinical specimen and you didn't know it, you'd hopefully be working on the clinical specimen under a biosafety level 2 cabinet. Once the organism is growing up on a plate and you were to do some tests on it, the second you thought it was a Francisella tularensis, again, just like Brucella, it would be reported to your local health department. The specimen would then get sent off to the health department, to CDC, because of it being on the list of bioterror agents. So this organism is highly pleomorphic. You can see teeny tiny rods, you can see long filamentous forms, and of course it's gram-negative. It takes 2 to 5 days for the organism to grow, and it doesn't grow very well on your 5% sheep blood agar plates. It prefers to grow on chocolate agar as minute, transparent, very tiny little colonies that look like small little drops. It does not grow on brain heart infusion agar or tryptocase soy agar, and like I said, it doesn't grow that well on blood agar. You can get that greening underneath the colonies, but that can make it look like it's alpha hemolytic. So if it were isolated in the lab, you would automatically notify the public health authorities. If it were suspected, if a physician were to see a patient and the patient had the history and symptoms, the lab should be notified to be very careful and to be on the lookout for Francisella tularensis. So it doesn't grow on or grow well on your typical sheep blood agar. It requires sulfhydryl compounds such as glucose cysteine agar or GCA agar. It requires enriched media, defibrinated rabbit blood. It needs thymine, and chocolate agar that's enriched with cysteine. It will grow on our commercial chocolate agar. It will form smooth gray, like I said, looks like little drops, little pinpoints, and it usually is slower growing. You can get colonies showing up after overnight growth, but in order to really see it, it takes a couple of days. So here is Francisella tularensis, and this is after 72 hours. And this is a chocolate agar. So absence of growth on your typical 5% sheep blood agar and growth on chocolate agar might be an indication. Slower growing, taking a few days to grow on media, having bipolar staining, so staining darker on the two ends than it does in the middle. You can do fluorescent antibody staining and agglutination testing. And here's a chart of your Fastidious gram-negative rods. If it's a zoonotic organism, that's catalase positive and indole positive, you might be thinking of Pasteurella. If it has special growth requirements, it needs cysteine, you'd think Francisella. You might consider your HACEK organisms, your Legionella, your Bordetella, your Capnocytophaga. So this is just an overall flow chart. It doesn't have a lot of specifics in here. We're going to move on to the 7th part of this Fastidious gram-negative rods. We are going to continue with part 7 of our Fastidious gram-negative bacilli lecture. And in this lecture, we're going to focus on the organism Bordetella. Bordetella has several species, 3 of which are clinically relevant. One of the species is pertussis, another parapertussis, and the third bronchoseptica. Some of the other species include Bordetella avium, Holmesii, Traumatum, and Hinsii. We're going to focus, as we usually do, on the clinical relevant organisms, and we start out always with our major pathogen of that group. So the major pathogen of the Bordetella organisms is Bordetella pertussis. Now, Bordetella pertussis has several virulence factors, one of which is filamentous hemagglutinin. And filamentous hemagglutinin mediates agglutination of erythrocytes. It is also involved with attaching organisms to the respiratory cilia. So the filamentous hemagglutinin and pertussis toxin being one of the major virulence factors that Bordetella pertussis produces, work together, and the FHA allows the organism to attach to the respiratory cilia, and the pertussis toxin starts to destroy the cells in the respiratory tract. And antibodies against FHA, or filamentous hemagglutinin, are protective. Now, the pertussis toxin resembles the diphtheria, cholera, and the Escherichia coli heat label toxins. It affects the adenyl cyclase, phospholipase C, and ion channels. And the effects of the toxin depend on the cell type. So the toxin can generate histamine sensitization, promote lymphocytosis, insulin secretion, and can inactivate immune effector cells. The toxin can also bind that bacteria to the ciliated epithelial cells along with the FHA that we just talked about, and antibodies against pertussis toxin do confer immunity to the individual. There's also tracheal toxin, and this toxin destroys the ciliated epithelial cells of the trachea. When tracheal toxin is working, it generates an accumulation of mucus, bacteria, and also inflammatory immune cells in the lungs. And that is what is is causing that cough, is the destruction of the cells and all this accumulation of mucus in the lungs, generating this cough that is known for Bordetella pertussis infection. The adenylate cyclase toxin interferes with leukocyte, or white blood cell, chemotaxis, so getting the white blood cells to that area of infection. It interferes with polymorphoneutrophil superoxide productions. So your neutrophils in your body can generate toxic oxidative radicals, and these oxidative radicals play an important role on killing bacteria that the neutrophils phagocytize. And of course, this toxin is also anti-phagocytic, so not as many phagocytic cells are going to be able to come in and gobble up the organism that's producing this toxin. The pathogenesis of Bordetella pertussis, someone that gets infected with this organism, we already said that the organism attaches specifically to the ciliated epithelial cells in the bronchial region of the body. The toxins destroy those epithelial cells. However, non-ciliated cells in that region of the body are not affected. So only the ciliated cells are affected by the toxin production. And you also get local inflammation, and you can get an exudate that's formed. The diseases, well, Bordetella pertussis causes whooping cough. 1 to 3 weeks, and it's usually between 7 to 10 days, is the incubation period, and there are 3 phases of the disease whooping cough. There's a catarrhal, a paroxysmal, and a convalescent phase. In the catarrhal phase, that has a 1 to 2 week duration, and it has very non-specific symptoms. They're very similar to a general cold, not feeling that well. It's in this stage of infection that the organism is highly transmissible. See, this person does not know they have whooping cough. They're getting some symptoms, thinking they're getting a cold, coughing all over the place, and this is causing the organism to be spread. The paroxysmal phase is the next phase, and it lasts 2 to 4 weeks. And here is where you have the very characteristic coughing, which it sounds like a whooping. And the reason for that whooping is because it causes such a persistent cough that people have a very difficult time breathing because you're just coughing. So in between some of those coughs, the individual's gasping for air, which generates this whooping noise. And there's a clip on Blackboard if you want to hear the very characteristic cough that is caused by Bordetella pertussis infection or whooping cough. In the convalescent stage, this can take weeks or even several months, but the individual usually has a complete recovery. Now, of course, an infection, especially one that lasts this long, can lead to complications. So you can get pneumonia, and this is usually a secondary bacterial infection. So you have Bordetella pertussis, you're getting all this damage, you're getting, this cough, exudate buildup in the lungs, and other bacteria will come in and infect the lung and cause pneumonia. And pneumonia accounts for the majority of the death due to Bordetella pertussis infection. It's been known to cause convulsions, hemorrhaging, hernias. I mean, you're coughing so much, usually the capillaries in the eye you'll get little petechia and capillary breakage in the eyes, and you could get a hernia, an inguinal hernia, where part of your intestine starts to come through the lining. Now, cases in the United States, there are cases every year throughout the United States, but if you look at the graph in the right-hand lower corner, you can see that there was a little spike of Bordetella pertussis infection in around 2004, 2005, and then another one in 2011. And these spikes of infection, and keep in mind this is the number per 100,000. So when you think of the entire population of the U.S., this is a pretty significant number of cases. So these spikes are due to a decrease in vaccination. Now, Bordetella pertussis is another species, and this is an opportunistic organism. It generates a similar disease to Bordetella pertussis, however, it's much more mild. The general characteristics of Bordetella are that it's a strictly human pathogen. So it's not sitting around, very long on surfaces. It's not an animal pathogen. So strictly human pathogen carried in the upper respiratory tract can lead to mild infections, and you can have asymptomatic carriage among adults that are immune. Transmission is usually airborne droplets through the coughing, and usually that's with people that are in close contact with an infected individual. The best way to prevent Bordetella pertussis infection and whooping cough is active immunization. So there is a vaccine, the DTP or DTaP, is given to children 6 years and younger, and there are 3 doses of this vaccine given. In adolescents and adults, the Bordetella pertussis vaccine is combined with diphtheria and tetanus. And usually, it used to be called DTP, diphtheria, tetanus, and pertussis. It's now called the Tdap, and it's given to adolescents at 11 or 12 years of age that either missed 1 or more doses of the original DTaP vaccine. It's also given to adults and pregnant women who have not been vaccinated. Now, treatment in an individual that is infected, very early on you can give antimicrobials such as erythromycin to decrease the transmission to other individuals. However, once a person has the disease, you're not really treating to get rid of the disease as much as trying to limit the disease being transmitted to other people. After the paroxysmal phase, usually the treatment is only supportive, so trying to get the individual to build back their lung capacity and stop coughing and repair those ciliated cells, and if they have a pneumonia or any of the other complications, to treat those. Bordetella pertussis is classically diagnosed by symptoms. A child who hasn't been vaccinated, has the characteristic whooping cough, is pretty easily diagnosed. In the laboratory, you can get a nasopharyngeal swab. However, it's important to note that it has to be a Dacron or Dacron swab and not a cotton swab. Now, direct plating is the absolute best way to diagnose Bordetella pertussis. So this is called a cough plate. So what you would do is, let's say someone is hospitalized, you would bring a plate right up to them and hold it in front of their mouth, and they would cough directly onto the plate. You would take that plate and immediately incubate it. Of course, you would want them to cough on media that's going to support the growth for Bordetella pertussis. And again, this is a fastidious organism, so it's going to have specific growth requirements. The organism is highly sensitive to drying out or desiccation, which is why a direct plate or the cough plate is the best method to collect the specimen. If the specimen is collected using a swab, you would want to use the appropriate transport medium, such as Regan Low transport medium, to transport the swab from the doctor's office to the laboratory. You can do direct immunofluorescent testing on a swab specimen to look for the organism. Now, the organism growing on an agar plate is very small. These are gram-negative coccobacilli, so teeny tiny rods. Colonies won't show up on a plate until about 3 to 5 days, so they're a little more slow growing than your typical bacteria. They generate small, glistening, compact colonies that are usually described as pearls or drops of mercury, and this organism is a strict aerobe. So here's a gram stain of Bordetella pertussis, and as I've said before, your gram-negative rods, it's very difficult to tell one from the other just by looking at a gram stain. I mean, you can tell that it's a Bacillus, a teeny, 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 tiny rod, so that might allow you to narrow down and think about your Bacillus organisms as opposed to your big, huge rods like a Bacillus species. But in general, you don't really want to look at a gram stain to get a diagnosis. It just allows you to say, okay, it's gram negative, it's Bacillus, and think about all of your organisms that are gram negative Bacilli. So that if some of you are making charts, that would be a chart that you would make. You know, start listing all of your gram negative Bacilli. Now, it is a fastidious organism, so it has specific growth requirements and the specialized media for Bordetella pertussis. One of them is Bordetella and another is Legionella. Now, for these types of media, we said the organism is very sensitive to desiccation. So these media contain fresh blood to absorb any toxic substances. They contain things like albumin, charcoal, starch, as well as antibiotics to inhibit the normal oral flora that would be present in a nasopharyngeal swab or a cough plate. And here's Bordetella pertussis on Legionella media, and you can see it does look like tiny little pearl drops. Now, Bordetella pertussis is a fastidious organism that requires charcoal, starch, blood, and albumin for growth. It is non-motile and it does not ferment carbohydrates. Bordetella parapertussis and Bordetella bronchoseptica are much less fussy. These organisms can grow on 5% sheep blood agar plates as well as MacConkey agar, whereas the Bordetella pertussis cannot. And Bordetella parapertussis and bronchoseptica are biochemically active, so you can do numerous types of biochemical tests, such as fermentation tests, to differentiate these two organisms. So we're going to move on now to the last part of our lecture. We're now in the last section of our fastidious gram-negative bacilli lecture. And in this section, we are going to focus on the genus Legionella, and specifically the species Pneumophila. Now, Legionella pneumophila is the most notorious species of Legionella that is associated with human diseases, and this is the organism that causes legionellosis. There are several other species of Legionella that we will not discuss because they don't cause a significant portion of human disease. Now, the virulence factors is Legionella is one of the organisms that is able to survive and multiply within macrophages. Now, macrophages are phagocytic cells that normally kill engulfed bacteria. However, Legionella and several other organisms, another one we've discussed is Francisella, are able to survive as well as multiply within a macrophage. Legionella also can produce proteolytic enzymes. Now, the organism enters the respiratory tract usually through inhalation. It can also get into the body through wounds. It generally causes a pneumonia, so there's an inflammatory response in the alveoli and bronchioles. Again, it is an intracellular bacteria where it can go in and live inside macrophages, which allows it to be shielded from the host antibody immune response. So antibodies will not be able to go and attack the organism because it's inside the host macrophages. And it can spread from the lung and enter into the bloodstream, causing bacteremia. we're going to talk about the clinical manifestations of Legionella. So Legionella pneumophila causes Legionnaire's disease, and this is an acute pneumonia. It was recognized in 1976, and how it was recognized is there was an American Legion conference in the late 70s, and numerous individuals at this conference ended up being hospitalized with a pneumonia. Several of these individuals ended up dying. And so when it was looked into epidemiologically, it was found that the majority of people that went to this conference were middle-aged men. And they found that the people that got more severe disease tended to be smokers or alcoholics, or had some type of chronic pulmonary disease such as emphysema, chronic bronchitis, asthma, things like that. Legionnaire's disease is a multi-system disease. The symptoms include coughing, chest pain in the chest area, like lung pain, and of course your pneumonia. And it can be fatal in immunocompromised adults, especially the severe infection tends to be more highly associated with men. Legionella pneumophila also causes Pontiac fever, which is a much more mild disease than Legionnaire's disease. It is an acute, self-limiting infection. There's no pneumonia, usually a fever, headache, some dizziness, muscle pain, and it is a non-fatal infection. Other infections that Legionella can cause, it can cause abscesses, postoperative wound infections, hepatic or liver abscesses, pericarditis or inflammation around the heart, myocarditis, bacteremia if it gets into the bloodstream. The organism can be treated with erythromycin, and erythromycin is good because it can get inside of the host cells to kill the bacteria. Now, the natural habitat of Legionella is that it is an aquatic organism. It lives in lakes, rivers, hot springs, moist, mud, soil, but that has to be moist. And it is found in contaminated sources. So it's found in shower heads, it's found in air conditioning cooling towers, as well as misting machines. So when you go into the grocery store and you happen to be standing in front of the vegetable section and you get that misting machine that generates moisture for the vegetables, it has been found there have been some outbreaks that have occurred due to supermarket misting machines. Now, transmission can be droplet aerosols. Commonly, it's usually due to aspiration of contaminated water or a wound that is immersed in contaminated water. So that conference that occurred in the late 70s, the American Legion Conference, and this was in Pennsylvania, what they found was that the organism was transmitted through the air conditioners. So they found the organism growing in the air conditioning water towers, and that was then getting disseminated through the air conditioning system. And these people were sitting in conference rooms, very small conference rooms. It was hot outside, and so the air conditioning was cranking all day long. So the best control for this organism is to disinfect the water supplies, heating the water to 60 degrees, at least 60 degrees, continual disinfection of air conditioning water towers in big buildings such as conference rooms, hotels. And the organism itself is relatively resistant to chlorine, so you have to use other types of disinfectants. To diagnose Legionella in the laboratory, the typical specimen, since it causes a pneumonia-like disease, would be sputum. Also, you can get a bronchoalveolar lavage, a transtracheal aspirate, a lung biopsy, and possibly you can do antigen detection using urine. But I'd say the most common specimen you would get in a clinical laboratory is going to be a sputum specimen. Now this is a gram-negative, pleomorphic. It has many different forms. There's filamentous forms, Coccobacilli to bacilli. It is motile, so it does have flagella, it moves. And the staining characteristics are that it does not gram stain very well. So in order to actually see this organism under a microscope, you need to extend your safranin counter stain for 10 minutes. You can also do a modified gram stain. So you would do your typical crystal violet and your iodine and your decolorizer, but instead of counterstaining with safranin, you would counterstain with a dye called carbol fusion. Now, culture of Legionella is required to definitively diagnose an infection with Legionella. Isolation of this organism is incredibly difficult. It's highly fastidious. It requires ferric iron, a hemin, a cysteine. It is inhibited by sodium ions and aromatic compounds. So the selective media that is used to culture Legionella is BCYE, or buffered charcoal yeast extract agar. Again, you should be going into the lecture notes from week 1 and finding your list of media, finding BCYE and studying it. Any media we discuss throughout this course is fair game on a quiz or an exam question. So the charcoal in the BCYE binds to the aromatic amines that are present. Now, on buffered charcoal yeast extract agar, the organism will grow as a grayish-white colony that glistens, and it's usually described as having a ground glass appearance. It is an aerobic organism. It does grow better in the presence of CO2. So you'd want to incubate your sputum. Sputums are usually incubated in a CO2 incubator so that you can get these fastidious organisms to grow. It is non-saccharolytic and it has slow growth. It grows, you won't see a colony for 3 to 5 days. Now, you don't have to speciate Legionella. If you isolate Legionella from a sputum specimen from an individual that has pneumonia-like symptoms, you know that this person has legionellosis and likely Legionnaire's disease, or possibly they could have Pontiac fever, but at any rate, you do not have to speciate it. If the organism only grows on a media that contains cysteine, such as BCYE, and will not grow on your typical 5% sheep blood agar, then that is classic for Legionella. You can use other diagnostic methods. You can use DNA probes, direct immunofluorescence, indirect immunofluorescence, ELISA tests, PCR, as well as urine antigen tests. Here's a gram stain of both intracellular and extracellular Legionella pneumophila. And you can see the organism is very difficult to see. It doesn't stain well, so it's very, very light pink. Very easy organism to miss under a microscope. Here it is again, extracellular and intracellular in a clinical specimen. And here's a gram stain, and you can see it is pleomorphic. There are some more filamentous rods, as well as some tiny coccobacilli. Here it is on buffered charcoal yeast extract agar after 3 days of incubation. So it tends to be a grayish white colony on BCYE. So this slide is showing a direct fluorescent antibody stain of a clinical specimen. So on the left you can see a lower magnification where you can see a lot of white blood cells, and you can see the apple green fluorescing little tiny rods. Now on the right in figure B, that is much more magnified, so you can really see the fluorescing green rod in that picture. Now here's a flow chart for the Legionella organisms. If Legionellosis is suspected, you would want to culture your specimen on your BCYE. You likely would also use blood agar, because classically it would not grow on the blood agar, but it would grow on the BCYE. And usually it's going to take about 3 to 5 days. So this is the end of our Fastidious gram-negative rod lecture. If you have any questions on this lecture, you can post them on Blackboard.